The patient's chief complaint is lower anterior mobility. Just observe and tell your observations. Lower anterior severe bone loss, especially the 3-1 and 4-1. And if you see lingually, there is bone loss in 3-2 and 4-2 also. And you can see this is proclined, especially the lateral to lateral is more proclined. And not only proclination, the canine is moving forward, creating gap between canine and premolar. So we don't know whether this gap has happened recently or is from eruption.
Happened recently.
Recently. Okay, that means the canine to canine segment is moving forward because of periodontal issue and because of tongue pressure. In this kind of cases, tongue also plays a pressure. 2 reasons. One is weight gain, and the tongue also gains fat. Then it becomes big in size and it gives more pressure. This is one of the reasons. And another reason is when a small gap is created, by habitually the tongue is probing that gap. So it leads to unconsciously, subconsciously the patient is giving pressure to this gap. So the entire segment is moving. So lateral to lateral has moved very much forward because bone loss is more there. Because the canine has got long root, it is sustaining, it is not coming outward, but however it is moving forward. Now the plan is to remove the 4 incisors. So we will plan how to place the implant. So first decision is which tooth you are going to remove. Lateral to lateral, canine no need to remove because it is in a reasonably good position. By doing gum treatment we can save the tooth. So only lateral to lateral we can remove and go for implants. So first decision is which tooth you are going to remove. Now it is clear, lateral to lateral. Second decision is how many implants you are going to place. Okay. So whenever you are removing 4 incisors, definitely it is not 4. Definitely it is not 4 implants. Either it is 2 or 3. If you place 3 implants where only 2 is necessary, needed, it will lead to implant failure. How?
Implants should be very close to each other.
Yes, implant will be close to each other. The implant will be close to the natural tooth. It leads to bone loss between the implants. Okay. Now we have to decide 3 or 2 implants. That decision, it is difficult to do with the panorama. If you see the panorama, you will think that you can place 1, 2, 3, 4. 4 implants you can place. Because the panorama is not the correct representation of the mandible. The mandible is a curved bone. But the panorama, it flattens the mandible and it shows to you. So there are a lot of errors will happen in this panoramic view considering the mesodistal dimension. It may look compressed or it may look elongated based on how you draw where you draw the arch form. Okay. See, I can shorten this arch. See, if you do like this, can you see they are moving forward? Okay. Can you see they are moving very much forward? Right? Now it looks they are moving forward. If you do like this, it will move away. So the panoramic view is not a ideal option to plan this, how many implants are needed. In the panorama it looks like you may place 4, but actually you cannot place 4. So this is the correct view. So mentally we are planning. Here one implant will come, lateral. Here lateral one implant will come. Okay, set in the midline we can place one implant. Right? And another reason is the arch is expanded out. So we are going to give the teeth inside. So when you are giving teeth inside, the arch length decreases. So that means less number of implant is needed. That is one other explanation. And another important thing to notice is what is the canine root angulation. Okay, whether it is distally tilted or mesially tilted. If it is distally tilted, it is ideal. Okay, if it is mesially tilted, it will become close to
the implants.
That also it is very difficult to understand from the panoramic view. You may get a lot of errors. Okay. In the panoramic, it looks like the canine is almost straight, but if you see the real view, it is slightly, it's not straight, it is slightly mesially tilted. Okay, here it is straight, right? Here it is straight. So when we are placing implant in this 3-2, I can tilt slightly distally, no issues. But if I tilt the implant distally in 4-2, where the canine root is mesially tilted, we may go close to the canine root, right? So this thing you have to understand. So when we are placing implant in this area, we have to be very careful not to tilt distally. Either go along the root, either go along the root of the lateral. Here, either go along the root, or you can slightly tilt distally. Instead of going straight, it is better to tilt slightly distally, because you will get more bone here for placing the third implant, the middle implant. Okay. Now we will do one thing. What we can do is, okay. So actually, this is the place available for us. Okay. Midline one, here one, here one. Now we have decided 3 implants. Now we will see. So what is the first decision?
Number of teeth to be removed.
What tooth we have to remove? Then
How many implants we have to place?
what is the third decision?
Where and all the implants has to be.
Location. Where you are going to place the implant. Which area? Okay. So it is very pretty straightforward case. Lateral, and third implant at the center, in between the centrals. Okay. So that is the third decision. What is the fourth decision?
The roots of the canine. The width of the implant.
What is the type of implant? Okay. Whether you are going to place BCS design or compressive design. Now we will see that. Okay. And on what basis we are selecting it. Now we will select a 4-2. Okay. This is the 4-2 cross section. Okay. Now see the labial plate. Okay. There is severe bone loss crustally, buccal and labial. But from here the alveolar bone is good. This is the intramedullary bone. It is not very much cortical. Usually we think the lower anterior, it is very cortical, D1. But here it is not like that. It is minus 20, 200, 300, something like that. You can see the ladder-like appearance here. This is the ladders. Each ladder is the cortical bone. This is the marrow space. The more marrow space and less this ready opaque line, that means the bone quality is poor. That is why here you are seeing, if you keep this arrow in the black spot, that is where the marrow spot, you can see 83. If you keep it in this white spot, it is 7. So this situation is not ideal for basal, because the basal gets its support only from the apical part of the implant. Here the bone is soft, so here it is better to place a compressive. So compressive implant gets support from the entire length of the body. When it goes into this bone, it compresses this loose bone. It compresses this bone laterally. So this cancellous bone is converted into a cortical bone, good quality cortical bone. This process they are calling as corticalization or bone condensation, whatever it is. Okay. So if you place the implant, then you check this number surrounding the implant, the bone value will be increased because it has compressed the bone. So here we will be placing compressive. Now we will be analyzing the 3-2. Here also the same scenario. Better to place a compressive, because if you place BCs here, it is only 60, 80. We won't get good stability. Now in the midline we will be okay. Here also the bone is cancellous. You can see 155 bone. But in the crestal region,
It
The
is
bone is good. Crystal of about from here to here. Okay. See here the bone is 532, here 950, 600 till here. Okay. So if you place BCS, when the BCS is entering here, it will be very strong. The moment it goes beyond this spot, it will be. And the midline there is lingual vessel is coming, which is dangerous. So you should not drill beyond this vessel. So that is why if you are placing implant in the midline, you should be very careful. If this gets disturbed, you will get severe bleeding in the lingual side, not more. Like threatening problems will happen. So you have to drill very short implant. You should not select a long implant. So what is the shortest implant? 12 mm. Okay. Shorter length you can choose it 13 or 14 mm. 10 or 10, 11 or 12, whatever it is. 12 is good. Okay. So till here it is 15. So 12 is safer. Okay. Here also disease is not advisable. Placing a short implant in the midline has got another advantage. What is another advantage? Apart from safety to the vessel.
Stability will be more in smaller implants. The force will be.
If you select a short implant, that is advantage in one aspect. One is avoiding the lingual vessel. Okay, you should read articles about lingual. There are some good articles about lingual vessel. Okay. The main advantage is we will be placing long implant here.
Okay, so that it won't interfere with the
it
other.
won't interfere with this implant apical. And if you select put a long implant, this may interfere with this. So third implant is just a extra additional support. It is not the main implant. The mesial and distal most implant are the key implants. In between implants are just supporting implants. So in the center, select a shorter length. So what is the diameter and length? Okay, here we can put a long implant also. Okay, around 16, 18. So if you put, there are three diameters we are using now. One is 3.75 and one is 4.2. So if you put 4.2, the implant will be very
wider.
Maybe wider. Crustally there may be little bone left outside the implant. So better to place 3.7, 16 or 18. Okay. If I am extracting canine, we will do 4.2 because the socket is wider. If you put 3.75, you won't get stability. Okay. So socket width determines the diameter and the quality of the labial bone. Okay. So 3.75, 18 or 16 or 18 will be better. Why we are selecting 3.7? Another reason is if we place 4.2, it will be more close to the canine. Okay, natural tooth also it goes close to the canine, and the middle implant also it goes close. So here we need to keep a safe inter-implant distance and distance between the implant and the natural tooth. So that is why that is another reason why we are selecting 3.15. Since we are selecting lesser diameter, we have to increase the length. Probably if we place 18, that is good. Okay. So we will decide whether 16 or 16 or 18 during surgery. Here also the same plan. Okay. Through the apex we are going, the angulation is correct. Okay. So till 18 it goes. Okay. Okay. So in the middle, what implant you have to select? With this, definitely here not 4.2. 3.75 will do, or any some other brand we can select 3.5 also. 15 or 13 or 12, whatever it is. It's just an additional implant. Very small diameter. Okay. So what is the sequence tomorrow? We have to give anesthesia. Not tomorrow, some other day or somewhere. Give local ventilation, extraction. Then do a small minimal alveolar-plasty. Reflect good flap. See the bone, crystal bone. Don't do blind drilling. Then you can drill and place the leg. Okay.